Good morning. Welcome to our module 4, that is the midface fractures. Midface fracture includes basically Lefort fractures. In 1901, René Lefort, he is a French surgeon who experimented on cadaveric skull using various weapons and then studied the pattern of various fractures. Then he has given the name as a Lefort fracture, that is the Lefort 1, 2, 3 and 3 fractures. Lefort 1 fracture. What is Lefort 1 fracture? Lefort 1 fracture is basically low level fracture. That is a horizontal fracture above the level of nasal floor. The fracture line extends backward from the lateral margin of the anterior nasal aperture below zygomatic buttress to cross the lower third of the pterygoid lamina. The fracture line also passes through the lateral wall of the nose and lower third of the nasal septum and towards the lateral fracture behind the tuberosity. Then coming on to Lefort 2 fracture. As you can see in this picture, this is a typical pyramidal fracture. And other name of this fracture is subzygomatic fracture. Where the fracture line passes? The fracture line passes from thin middle area of the nasal bone down either side, crossing the frontal process of the maxilla into the medial wall of orbit. Within orbit, the fracture line crosses the lacrimal bone behind the lacrimal sac before turning forward to cross the infraorbital margin slightly medial to and through the infraorbital foramen. The fracture line now extends downward and backward across the lateral wall of the antrum below zygomatico-maxillary complex and divides the pterygoid laminae up to their halfway. And separation of this block from the base of skull is completed via the nasal septum and may involve the anterior cranial fossa. Now, what is the Lefort 3 fracture? Lefort 3 fracture are the higher fractures, high, transverse or suprazygomatic fractures. See, these are the suprazygomatic fractures. Or according, because of this fracture, we can have craniofacial disjunction. The fracture line passes from the near the frontonasal suture transversely backwards, parallel with the base of skull, involves the full depth of ethmoid bone, may include the cribriform plate. Within the orbit, the fracture line passes below the optic foramen into the posterior limit of the inferior orbital fissure. And from the base of the inferior orbital fissure, fracture line extends in two directions along the pterygomaxillary fissure to fracture the root of the pterygoid laminae and laterally across the lateral wall of the orbit, separating the zygomatic bone from the frontal bone, that is frontozygomatic suture. Now, what are the various clinical features of the Lefort fractures? See, with the Lefort fracture, patient can have facial edema, ecchymosis around the labial or buccal vestibule. If palatal tear is there or mid-palatal split is there, patient can present with the palatal laceration as we can see in this picture. Malocclusion can be there or anterior open bite can be there because of the posterior gagging of the occlusion in the posterior region of the maxilla. Then you can feel the mobility of maxilla with while the nasal bridge remains stable. See in Lefort 1, nasal bridge remains stable. While in 2 and 3, you can see the mobility of the nasal bridge area. Sometimes there is downward, upward displacement, impacted or telescoping fracture we can see in the Lefort lines. Bleeding from the nose due to hemorrhage into the maxillary antrum. And there is crack pot sound on the percussion of the maxillary teeth. In Lefort 2 fracture. In Lefort 2 fracture, there will be marked facial edema. That is the moon face will be there. And circumorbital ecchymosis or edema will be there. Subconjunctival hemorrhage can be there. See, nasal flattening can be there because it involves the frontonasal region. So, nasal flattening can be there. Because of this, patient can have traumatic telecanthus or epistaxis or CSF rhinorrhea is there. As there can be fracture of cribriform plate, patient can have CSF rhinorrhea. Elongation of face due to downward and backward displacement of fragment with posterior gagging of occlusion or anterior open bite can be there. Step deformity you can feel as there are the pyramidal fracture, we can feel the step deformity as infraorbital rim, zygomatic buttress or frontonasal suture area. See, fracture line passes through the infraorbital foramen, so we can have paresthesia of the cheek region, that is the infraorbital region. In the Lefort 3 fractures, there will be gross edema of the face. Again, there is gross edema of the face. Panda faces appearance is there. Raccoon eyes, redness around the eyes is there. Supraorbital ecchymosis is there. Bilateral subconjunctival hemorrhage is there. Tenderness and step deformity we can see at the frontozygomatic suture region. Dish face facial deformity is there. Epistaxis as well as CSF rhinorrhea can be there. or CSF atoria can be there in some cases. Depression or ocular level, that is, hooding of eyes is there. Or patient can present with anophthalmos, diplopia, or visual impairment. Orbital dystopia with anti-mongoloid slant can be there. Or mobility of leaf for 3 fracture is confirmed by moving the maxilla from the nasofrontal and frontozygomatic sutures. We can go for various radiographs. Most common is the posterior anterior view of the skull or Waters view, that is occipitomentalis view, or submental vertex view we can say. For CT scan, CT head, CT face with 3D reconstruction. As we can see in this picture, there are various patterns of fracture for the midface fractures. Orbital CT, we can go for seeing the orbital fractures. What are the various treatment options for the midface fractures? Basic treatment option for all the fracture is the reduction, fixation, and immobilization. In this picture, we can easily predict the Leaford 1 fracture. There is down fracturing of the maxilla is there, so we are reducing it with the Rose disimpaction forceps. Disimpaction reduction of maxilla. Initial traction is applied by cocking the wrist upward to affect the disimpaction of pterygoid plates in downward direction. Traction is applied in downward and forward movement to mobilize the maxilla parallel to the incline of the base of the skull. Now, if there is mid-palatal split or paramedial split is there, so flaring of the palatal is there. In that case, we need the Hayton-Williams forceps for the anterior traction in case of split palate and may be facilitated by use of special forceps, that is the Hayton-Williams forceps. Open reduction and fixation of any commitant fracture, that is nasoethmoid, orbital, zygomatic bone fracture using transosseous wiring or bone plating can be done. Internal or external skeletal fixation is also useful in case of maxilla. Temporary intermaxillary fixation is required. Reduction or nasal fracture should be done, or definitive intermaxillary fixation is required in some cases. Rigid fixation. Rigid fixation we can do with different types of the plating system. We can use mini plates, that is their profile can be 0.6 to 1 millimeter thickness. Microplates for the infraorbital fractures we can use, or along with the frontal fractures or naso-orbitoethmoidal fracture. 0.5 to 0.6 millimeter thickness is there. Mesh we can use if there is floor of orbitis fracture. 3-dimensional plate we can use, or resorbable plate in case of young patients. Or there are various fixation devices are there. Circumzygomatic fixation, headgear, or transosseous wiring is also there. External fixation, you can see halo frame or Levant frame. It was used in the earlier years, but nowadays it is not used. We conclude with this in the Leeford lines or midface fracture that early and definitive treatment plan is mandatory to avoid any post-traumatic complications. Maxillary fracture can sometimes occur with significant cosmetic and functional implications. Accurate diagnosis and early surgical intervention is essential for successful management of these fractures, and surgeons should always keep in mind that surgical management of maxillary fracture primarily aims at restoration of vertical as well as horizontal support buttresses. Thank you.